invitation to join in this meeting. This is really a pleasure to be here. So I'd like to talk to you a little bit about what's going on in the United States, and I will repeat some of the slides that you've seen before from work from Paulo Moraro, but I will jump a little bit faster just to make a point. I'd like to just sort of give a little bit of some thoughts about the issue that we just touched upon now about patient access to this, which is it's been an issue about coverage and so forth. So here in my disclosure slides. So the way that I put together this presentation is just to look at the landscape. We have much lower activity in the United States than you have in Europe, and just a subset of these cases are reported to the registry. So I'd like to show that to you. There's some different trends with the publication of the recent trials, and just a little bit of overview of what's going on with MS, and then we'll talk about the BMS, which really the inception of this was this collaboration between the U.S. and Europe with Ricardo and Paulo and the Canadian group to try to think about a study to be developed. And after a long time, the study has been sort of available right now, and it's been released to centers this year. And a few additional considerations. So this is the summary slides that all know about the activity in CIBMTR. But if you look at 2017, this is really accounts for a small amount of patients being transplanted for autoimmune diseases. If you plot them out since the inception of these transplants in 1996, you can see here the activity in blue of autologous transplant and green allogeneic transplant is sort of fluctuate over the years. And I think that has to be related to some of the, these are all voluntary reporting, and there is a little bit of fluctuation on it, but perhaps you can draw a line that's slightly increased in the last few years in terms of the activity. If you look at those, the breakdown, multiple sclerosis is the most common indication of these transplants, and if you look based on these indications over time, you can see that at least the green bars in your histogram here, there is an increase in overall transplant, mainly related to the more activity on the auto transplants. It's really important to know that this is not representative of the United States. CIBMTR collects information in other countries as well, and there has been an insurgence or a really increased number of activity in transplant in Latin America, and those are reported, some of them are reported, included here as well, but as not representative. This is really compares to, does not compare to the activity in Europe, which you can see here, that autoimmune disease is among one of the most increased indications in Europe as regards to the Ebmt. So this is also a report from the Ebmt, just to look at safety of transplant. We've been accumulating data in the last 30 years, demonstrating that there is really a role of transplantation for these patients, and the field has evolved to understand some important questions of who and when we should transplant, but there's still a lot of questions that need to be answered regarding the best use of this approach. So I put forward a few questions about this, and I'm incorporating the BMS in the middle of the presentation. So who can benefit from the transplant? And this is really a subset of all patients that we now know that are young and fit and have a relapse-remitting disease, that have rapidly active disease. And this is really important to know, because when this data is disseminated to patients, there is really, I need a transplant right now, but not all patients with MS really require a transplant at a time, because they would have a more benign course. That's really important as a dissemination to the field to understand who will be the best patient to undergo this procedure. So here is the same information about the types of patients who are most benefit from this. And in fact, the field has evolved in transplant. This is the data from Ricardo, not updated, but updated in 2015, to look at really the landscape of these patients that change from more of a progressive form to a relapse-remitting form. And this is really the focus, is to really to have the patients that will acquire the most benefit from this procedure, and to catch the disease early in a highly active inflammatory instead of in the progressive form, which the benefits are not as much, but toxicity can be excessive. So what are the efficacy of these transplants? I think the question is we need more comparative studies, as you heard the last two presentations. The key thing here that I would like to outline in the next few slides is the fact that these randomized trials are really difficult to do, because as soon as you put a trial in, the patients who are coming and committed and then are randomized to a no transplant arm, then there is dissatisfaction of that. So that sort of is a really a very important point that we have to deal as we develop these trials. So this is an outline that was published recently to try to convince the U.S. community, mainly the payers, to try to approve these transplants, to try to accumulate all the data and allow the centers to use this data to reference this position paper from the American Society of Bone Marrow Transplant to try to do these transplants more often. So here is this first slide is the number of phase 2 trials. I will not belabor the point, because most of them were done in Europe and most of the activities in European centers. But you can see that there is really a variety of types of patients and types of endpoints that are designed. And then you have the two comparative trials that you heard before here, the Estens and this trial, and with seeing some slightly difference, which I'll go into more detail in the few slides. Here is the analysis that Maria Pia and Paulo put together to really looking at comparative over time of therapy initiation and at a time point of 2 years to look at really this new and composite endpoint of no evidence of active disease to determine the success of the transplant. And when you look at this, you can think about, oh yeah, that's really easy to design a trial because the difference is 30% or 40%. We only need 20 patients. But then when you start designing the trial, then you start seeing the problem of identifying the right control and all the questions that we had really answered earlier. Also the question of the conditioning regimen as well. So this trial was presented last year as a international trial with involvement of the countries listed here, and it was back in award last year. It was really important for us to have this study available, even though there are some caveats on the patient selection and the treatments that were allowed. Because as soon as you start the treatment, as Ricardo was saying earlier, by the time you get the results, the neurologist community will say, well, that was not a very good control because of X, Y, and Z. So I'm not sure, that's really another point of discussion. But you heard this from the last speaker about the difference. I think the one important point is to outline that they selected to use a side-ATG conditioning, and then the disease-modifying was, of course, which mitoxantrone was excluded, but also excluded lantuzumab and eculizumab from this from obvious reasons. They're not either approved or because of other complications, but it really weakens the control arm, and there was this washout period as well that these patients entered. But it was really interesting, the fact that there was a decrease in the disease activity and disease progression on the paper. But most importantly is the fact that there was improvement in the DSS. And you don't see that very often in non-transplant trials. And so if you catch these patients early and they have rapidly active disease, inflammatory, you can actually improve the neurologic function with the transplant. So that leads us to the BMS trial, which is its best available therapy. And versus autologous transplant. And this is really a trial that's been discussed for a long time already, but then it was really finalized with the collaboration of Paulo and Jeff Cohen in US in neurology and a group of transplant physicians. So the summary of the trial is that so you have a population who is relatively young, a DSS of 2 to 5.5, and you have to have a highly active disease defined by greater than 2 relapses in the last 2 years. The N of the is 156 patients, and then the best available therapy is anything, pretty much, so that strengthens the control. And if it's really in one country, which really is an advantage of this compared to Europe, when you have variability of available treatment regimens, here you can basically have in a single country which you have all of these available as a comparator. And the choice of conditioning regimen was being a little bit more detailed. The main point here is the MS relapse-free survival, which is slightly different than the NIDA, and it'll be really a long-term study to try to understand long-term outcomes of this. And then you have a list of secondary endpoints. So this is also a paper that was published by Paulo to look and then understand the rationale of using some of these conditioning. Of course, the higher the intensity, you have more toxicity, but the lower the intensity, it seems that you have escaped the disease. So I think that's the comment about having a weak comparative within the transplant, because not all transplants are the same, and I think that's important to know when we choose this conditioning regimen. But we still to date, we don't have a head-to-head comparison with enough patients to compare one versus the other type of regimen. We tried to do this in the collaborative Ebmt CIBMTR study, but we didn't have enough power to detect a difference between the two regimens. In the United States, the breakdown of these cases for multiple sclerosis is mostly CIATG, which comes in from the experience from Latin America, which mostly use CIATG for those. So the hypothesis that immunoablation reconstitution of the immune system, which is the preferred term from the neurology community, with a autologous stem cell, is superior to a target biologic treatment or best available therapy, providing highly efficacious and durable control of MS disease activity. So that's really why the study is being done. A little bit more detail on how the highly active disease is defined here, and within the last 24 months until enrollment. The initial time of the study is actually the first initiation of therapy or the mobilization, because as you know, the mobilization or preparation for mobilization is part of the treatment of MS, and that should be counted as an intervention for these patients. So let's talk a little bit about patient access to transplant. So I think it's important to mention that not all centers should do this just because they do autologous transplant for lymphoma. This is a different kind of transplant. I think it needs to have a learning curve. I think the importance of supportive care and nursing care are really should be really paid attention. And then the other issue that we heard a little bit here is about coverage of transplants, which is the United States is a huge issue. You just can't do these transplants because they're not routinely covered. So I think I thought this was very interesting from the NIST trial, so they launched it so everybody knew about the trial. So they had 900 patients screened to 110 randomized. And I think it's important to understand why this failed, right? Because I think there is an issue about miseligibility. So you think the patient's eligible, but then when you look, they're not eligible. But the fact here is that you have a large number of patients who have active MS, they are on treatment, but not all of these patients will fulfill this criteria of relapse remitting with highly inflammatory disease. And that's why that's very important to define in every trial, because you don't want to treat patients that are not they're not needed. But there's still a small percent of patients even in this trial, and most of them in the U.S. that didn't really have insurance coverage to have this trial done. And the other really important aspect of this is that patients will find a way. So if they get it randomized to a non-transplant arm and they really wanted to do a transplant, they'll go find a transplant. And there were about 31 patients who crossed over to the transplant. And in the NIDA curve, you saw that there was a high number of patients who dropped out because they were censored at time of progressive, and then when they went to transplant. So the fact here is that patients will find in the United States, they can just go to a different country, routinely either Canada or more frequently to Mexico to have the transplant done there, paid in an outpatient clinic. So I think that's important to know that we need to work on the access for these patients, and because as we put this data together and we show out in our papers that this is really highly active, first we have to, the message is not all patients are eligible for transplant. And number two, the patients who are, we have to make sure that they have access to that procedure. And then the last point that I'd like to make is sort of the outlook on the transplant in the future, because there's not really only an improvement in transplant technology, but also an improvement of these disease-modifying agents. And I just want to make a note of this paper that was published last year about the effect. This was a very large registry study based on non-transplant. This is a non-transplant study. But it looked at the evolution of treatment. So disease-modifying agents really modify the natural history of MS, which means that with these new therapies, there is a less proportion of conversion to progressive MS, which means is that the number of overall patients living with relapsed remitting MS will increase. So especially with the newer agents, figolimod and alemtuzumab, natalizumab. So, but the downside of this, you have more patients requiring chronic therapy, and these therapies oftentimes are not as safe, as they have cumulative toxicities as well. So you're going to have more patients with that relapse remitting really phase of the disease, which might be another niche to focus them in transplantation later on. There was a lot of conversations with the neurologists about how should we limit the time of transplant. For example, should we do only 5 years? Should we do 10 years? But more and more, you're going to see patients living with this and being treated chronically with these agents that should be considered for transplant. So my conclusions are here is that the data accumulated, now we show that really we have a very effective therapy, but it's not for 100% of patients. I think the BMS will be really a supplement the data that we have, because now we can compare with any control, and we also have a more intense conditioning regimen. And I think the challenges remain, because now we're showing the therapies available. We have to make sure patients have access to it, and I think we need to focus on center practice to maximize safety, and not really have this available in only a few centers in different regions. So with that, I'd like to give some special thanks here to the group from BMS. I learned a lot with Paulo and Ricardo over the years about MS. I really appreciate that. The collaboration with the Autoimmune Working Party, John, Dominique, and Ricardo, and then the folks from the CIBMTR Autoimmune Committee. So thank you for your attention.